Thank you for kind invitation for ICAR's conference. I'd like to say a few words about Chwala procedure. Last year I described the procedure, the technique of the procedure itself. All the recording is available on the web page. I'd like to recall that Chwala procedure is what we can do for the patients with short infrarenal neck as off-the-shelf option. It is suitable for about 18% of the patient that could be excluded from EVAR because of short neck. This is procedure that can be made in emergency treatment. It's FDA approved and CE-marked solution. So to recall the anatomy of the endurance graft, since we are using balloon expandable covered stents, we have to land below the pins of the graft and above the covered part. So we have like 3 to 5 millimeters of the zone that we can safely land our additional stent graft. The first patient is 75 years old male, admitted because of abdominal pain. He had 76 millimeter aortic aneurysm, high operation risk, numerous concomitant diseases, and he was previously operated for prostatic cancer. Because of those diseases, we decided to go for EVAR procedure. However, during CT, we discovered he had a bad blister located at the level of renal arteries. We were afraid that we could cause dissection during normal procedure, and we decided to cover this blister during the stent graft procedure. So we start with putting 2 thermodestination sheaths in both renal arteries. We are working on supracore wires. We then switch into a lateral view because we are trying to land just below the edge of superior mesenteric artery. Renal arteries are of no concern because we will be landing chimneys in them. And as we can see, we gain about 1 centimeter above the blister with to cover with stent graft. So we start to deploy the endurance graft, still having both covered stents in the sheaths in renal arteries. After the endurance is fully deployed, we switched for horizontal plane. We go for big magnification, the highest possible quality, and we put the lamp in order to have alignment of all endurance markers. Then we remove the sheaths from the stent grafts, deploy the stent grafts. We remember to keep the sheaths at the level of the pins in order to avoid puncture of the balloons. Then we retreat sheaths into stents and we go for ballooning. This is very important to remember the order of the ballooning because we don't want to squeeze the stent grafts in renal arteries. So we start with putting balloons into renal arteries, then we inflate reliant, then we deflate reliant, and finally we deflate stent balloons. After deployment, we can see a metal wire frame of the stents and stent graft. During final angio, we can see the blister is excluded, the aneurysm is excluded, and both renal arteries and SMA are patent. We can see the same at horizontal plane. Next patient is 76-year-old female. She was admitted to hospital because of lumbar pain. She had aneurysm of 87 millimeters, also high cardiological risk, numerous concomitant diseases, and she was obese patient. That's why we decided to go for EVAR procedure initially, but we discovered that she had very short neck below left renal artery and additional renal artery. So, as we can see, there is big distance between left and right renal artery. Superior mesenteric artery is located even more above. So we decided to put one chimney. We cannulated left renal artery. We put the coil into the additional renal artery. We working with horizontal plane because we are locating the graft below right renal artery. We do not consider the problem of SMA this time. So we start deployment of the graft. As we can see, anatomy is really tortuous at the neck of this aneurysm, but thanks to the structure of endurant, as we can see, those relatively narrow rings that are numerous and dense really align very well with the anatomy of the neck of aneurysm, as well as the stent graft put into renal artery. So we achieve good sealing, there is no endoleak, and all important vessels remain patent. Third patient was operated because of Leriche syndrome, not because of aneurysm. He also had very high operation risk and hostile abdomen because of operation of ruptured gastric ulcer in the past. So as we can see, we discovered big inferior mesenteric artery in this patient, and we are really afraid to cover it during the procedure. As we can see, it's also visible on the angiography, and it is connected with arc of Riolan. So we were afraid that we could cause gut infarction during the procedure if we covered this vessel. So during CRAP procedure, we are using 3 big grafts, one main body for aorta and 2 legs for iliac arteries, but this time we added chimney made of big graft as well. As we can see here, we managed to protect the inferior mesenteric artery, and we can see it is quite important vessel because internal iliac arteries are not very well developed in this patient. In finalgraphy, we can see, well, all this pelvic circulation dependent on inferior mesenteric artery. So we can combine chimney procedure with CRAP. This is out of IFU procedure, but it's sometimes even easier than using with classical stent grafts because there are no pins on aortic part of the graft. There is no problem of endoleak because we are dealing with not patent vessels. This is not suitable for aneurysm with Leriche syndrome because there is no tight connection between parts of the CRAP. And we'd like to remind that it's sometimes well to consider using 3 balloons for kissing if EMA is close to the legs in iliac arteries. We performed so far 3 such procedures with no complications in the patients with Leriche syndrome.